The first of those is the development process. So how do we develop these automated systems? If we're going to have therapeutic, more complex systems, how do we develop them in such a way that we have some uniformity in that development process? And then the second thing I want to do is I want to share some of the data that we have in the development that we've done with opioid-dependent patients that are already in opioid agonist maintenance treatment. So the most effective treatment for opioid dependence is agonist maintenance, and that can be provided in two different contexts. It can be provided in methadone clinics, traditional methadone clinics, where patients come in and receive their medication on a daily basis, usually. And they receive their medication on a daily basis, and they're provided with other services such as individual counseling or group counseling. A more recent development is the use of buprenorphine. And buprenorphine can be provided in a regular primary care context. It can be provided as a prescription for patients on a weekly, 2-week, or even a monthly basis. So patients come into the same primary care context, they receive their other care, and they can receive treatment for their opioid dependence in that context. Unfortunately, one of the things that we do know is that we know that adding behavioral intervention with these two different types of treatments ends up making the treatments better. So if you have individual counseling or group counseling, in addition to receiving the medication, people do better. The problem is there's a lot of limitations to providing those. Those include costs, training and supervision of counseling. If you think of primary care context, that can be very difficult. But even within traditional methadone clinics, there's often a high turnover rate of counselors. There's constant training and supervision that needs to be done. There's also staff interest and training within that setting. So if you consider perhaps nurses being used to provide treatment for opioid dependence in a primary care context, oftentimes there may not be the same level of interest in providing that care because they were trained as nurses. Space is always a premium, and it's becoming even a premium within methadone clinics. You have issues of coordinating care if you provide it off-site, and you have finally patient problems. When patients come into treatment and they initiate treatment for this problem, they want to get their life back. They want to go back to having their job. They want to go back to being with their family and doing those other real-life things. That means that their time is being taken up by those other things. And so they have less and less time that they want to say, okay, yes, I'll go spend 2 or 3 hours a day receiving behavioral interventions at a separate clinic. So they want to get on with their lives as much as possible. There are a number of advantages that we can provide for providing automated mobile treatments. So those are sort of counter to the other limitations. They provide automated treatments can provide options for many therapeutic interactions. And I say mobile treatments here, so what I'm talking about for mobile treatments and focusing on is treatments that people can use anywhere, that they can take anywhere, they can use on a cell phone or a smartphone or other device. Those can offer potential for many more therapeutic interactions. It can be provided within the setting, where they're having craving, where they're having their withdrawal symptoms. It provides a high degree of confidentiality. Patients often don't like talking with a therapist or a counselor or in a group setting about their use, and they may feel that that is not private, and they'd rather have a way that they can have interactions and work on their behavior in a way that feels more private to them. They're obviously low cost, and they provide consistent presentation, and they provide increased availability and treatment for rural and remote settings. So I want to talk about IVR systems. Previous presentation presented a straightforward IVR system. We have started to develop a more complex set of systems that we call therapeutic interactive voice response. They require a lot more interaction, and there's a lot more content available than just a small number of questions. Their advantages are they're very low cost, they're centralized, they are flexible, mobile with a cell phone. They can be used anywhere, 24 hours a day, anytime. They're highly accessible from any place, and they're what I like to call a low high-tech. Patients know what these systems are. They're the same system for any company you call and you receive a phone tree. That's a computer behind it directing your call. This is the same kind of thing, it's just more complex. So they're familiar with them, and that makes for a higher level of comfort, even though they can be highly complex. In addition, they're easy to adapt and change based on feedback and updates in the science. So what we've done is, over the past couple years, we've developed a system for our development, an approach for our development procedures that involves an array of stages that are iterative, in that at each one level we want to meet a specified a priori criteria. I've listed or shown two different levels here. There's two different, one is for buprenorphine and the other is for methadone. So there's two different parallel processes. It starts by a system of generating and editing initial modules that are based upon a theoretical approach. So based upon, in this case, cognitive behavioral therapy. The second layer is then to evaluate those modules based on counselor acceptability and feasibility, and to get quantitative and qualitative information back from those that is then used to generate and improve on the system. The second level is to use that same sort of approach, but with experienced patients that are within that setting and experienced with the treatment, and then to do a feasibility level of that same thing. So the key here that I want to point out is what we call, is our criterion that we set ahead of time. And finally, we have, I have some initial data to show you for initial efficacy too. Acceptability and feasibility criteria. We're trying to set these ahead of time so that we know what we have by the time we get out. When you're a therapist, the person sitting across from you is giving you constant feedback about what's working for them, what isn't working for them, and whether they understand words, all of those important things. When you have an automated system, you don't have any of that. Okay? You have to have it reach a broad group of people first. And I would like my idea of what a great therapeutic intervention to be perfect the first time, but I know that that's not necessarily the case. So we have our acceptability criteria, and the idea is that we want a majority of our population to be comfortable with it. We want them to like it. So we have a 5-point rating scale: interest, helpfulness, and ease of use. So we want the majority of people to like that, have ratings of 4 or 5 on that scale. And we want them to use it. So we want them to like it and then to use it. So the evidence of use we want, and this is free, open-ended use, we want the majority of the patients to use it for more than 30 minutes. That is an arbitrary criteria at this point, but it seems comparable to what patients often receive when they're receiving behavioral intervention. Next, we want the majority to use it relatively frequently. So we want them to use it more than 50% of the days. So this is the initial flowchart of the initial system. This was their first pass at this system. And what we had was, we call it the recovery line, which is a comfortable term that our patients seem to like. They have a secure login. If you call this number and you don't have a login, you don't get access. They have an introduction for first-time callers, and then they have different, an array, a menu for different types of options for the modules. There's help modules, assessment. There's learning about, which is breaking up the classic CBT into explaining the concepts and then working with or practicing the skills. For us, we have our activities being related to the different skills. And then we have what we call an inspiration section, which was the idea of trying to have something to get people interested in coming back. Okay, so for substance abuse counselors, we evaluated this for both buprenorphine and methadone, and we had individuals review the system and provide feedback regarding the acceptability and of the system content. So 6 CBT therapists that were experienced treating buprenorphine clients provided some acceptability criteria, and then 9 methadone counselors. And our acceptability criteria was met. We had greater than 50% of counselors from both groups say that they thought it was interesting, helpful, and easy to use. Same sort of thing we found with our patients, with our initial evaluation of patients. What we found is that of 16 patients that were evaluated for bup and 12 that were evaluated for methadone, they met that level of criteria. For acceptability, you can see the buprenorphine, it was 69%, and then 81% for helpfulness and 89% for ease of system use. For methadone, it was 67% interest, only 50% helpfulness, and 92% ease of use. So we had to make some changes. We got a lot of qualitative feedback from folks too, so that meant that we could take their feedback that they've given us, take it from the counselors, and improve on what we have. We've done that. One of the first things, we got rid of any machine voice. Any voice that's a machine generated, everybody hates. You have to replace it with a person that's a recorded message. We made the modules brief. People didn't want to spend a lot of time on this. They wanted to get in and get out and get something useful out of it. We wanted it to be patient. We made it patient-driven rather than session-driven, because that's what feedback was. Patients wanted to be able to say, I want to use this when I want to. I don't want to have to go through a 45-minute module in this type of context. They wanted to do activities rather than skills practice. When we had it say skills practice, they found that weird because they were going and doing the thing. They didn't regard it as a skill they were building. And we wanted to keep the language simple, not dumbed down, so we had a review by plain language experts. We wanted interactive and engaging. We did that. We evaluated the feasibility of it, and we found that we had pretty good feasibility. 84% were using the system for the week access that they had, greater than 30 minutes for the BUP, and they called about 5 times. Most of them called more than 50% of the days, and the average call length was about 10 minutes. Similar types, except slightly better for the methadone side, more calls, more time, and slightly longer call lengths. We made some additional changes. People thought that we should have more content. We added more content. We added the capacity of the system to have different levels. So if they used the system a certain amount, they got access to more content. We included 3 daily questions asking about how you're doing, whether you used in the past 20 or since the last call, and whether you've taken your medication. And then we've added some other type of resources and other types of modules to the system. Right now, we're doing a randomized pilot. I'm in the middle of it. I have a smaller sample. This is combined data I'm going to show you. It's a 4-week trial. It's recovery line plus treatment as usual or treatment as usual. So it's a very straightforward design. Inclusion criteria of being on one of those 2 medications, using illicit drugs in the past 30 days. So we want to have something to work on. You know, we don't want to have this be for people that are doing really well. So it's for people that are not doing so well. 18 years or older, read and understand English, and if they were suicidal or homicidal or had bipolar psychotic disorder or had a medical condition, they were not included. This is my first sort of most promising finding, which is that the self-report seems to decrease. The green bars represent individuals that receive the recovery line. The left is prior to treatment, so the month prior to treatment. They had about 12 days of reported use. That went down to about 6 days of reported use. For the treatment as usual condition, it stayed the same. Okay, so this is marginally significant. That is correct that it's equal to 0.05. Or yes. So in addition, the other outcomes are also tentative, but they're in the right direction. For urine screens, there's about a 20% difference if you look at the percent of abstinent from all tested drugs of abuse. So the recovery line and treatment as usual had about 50% of abstinence from all drugs, and the treatment as usual had about 28%. So you can see this is a pretty, these folks are still using a lot. These are maybe in methadone agonist or opioid agonist maintenance, but they're still using a lot of drugs. In addition, if you look at the number of drug tests, there's in favor of, again, the recovery line treatment as usual of 0.8, about 0.8, compared to the treatment as usual 1.2. So it's suggesting that the polysubstance use of this group is potentially reducing somewhat. We looked at situational confidence a bit, and again, there's a direction, but it's a non-significant direction. And this finding at the bottom is probably the thing I'm sort of most interested in. We had 5 people tell us that they reported that they used the recovery line instead of using drugs. Okay? That they stopped a lapse. And I think that given how low cost many of these treatments are, that this may be where we're getting our most benefit. We may not have to have a huge treatment effect to have something that's useful. And I think the cost effectiveness means that we have to really evaluate that. That becomes more and more important. All right, this is a quick idea, another point too. Each of the dots represents a dot of a call of time. The point I want to make here is that the box over there represents clinic hours, and everywhere else is non-clinic hours. So people are calling when the clinic's not open. And I think that as well is really, really important point to take home, is that this is a useful add-on because it's provided when people aren't getting their usual treatment. Some additional information about calls and a few other things about one of the other components on the bottom here. We've had 200 people, of the 200 people that have called and answered our question, our initial daily questions, 25% or 50% reported that they'd used since their last call. When they did that, then a large majority ended up going on to use a module that was specifically intended to help them with that circumstance, to do urge surfing or to recognize and understand triggers. So they're using the system therapeutically, I believe.